groups, and particularly chiropractic group, and I've got a lot of interaction with chiros, and quite often we'll chat about patients, and I really think that's a good way to practice. And I wish a lot of my other colleagues would also embrace a more holistic approach. We don't have all the answers as a group, as surgeons, we certainly don't, and I'm sure you guys feel the same. So I think collectively we could probably practice better for the patients in terms of putting our knowledge together with chiros, physios, EPs, rather than kind of all working maybe separately, with the same patients. The other thing is, I guess the role of surgery for most patients that you'd see is obviously minimal. So, I might see, if I see 30 patients in a day, you might find a third of them, or not even, sometimes even a quarter, that actually need a procedure, or sometimes even less. And those are patients that have been seen by our GPs and then referred thinking they're surgical candidates. So the reality is, don't take this talk out of perspective. The reality is most patients actually don't really need surgery, and the ones that we sort of operate on, we really have a responsibility to picking out those patients that we think are going to do well with surgery. And that's a big skill, and that takes a lot of experience. And I know some good surgeons, and then I know some bad surgeons technically, but then also the other whole side of the discipline is choosing who you should operate on. And sometimes that's quite hard because you think patients might do well and some do poorly, and you really have to try and tease out those that are good surgical candidates. The other thing that's crucial is whenever I see a patient, you have to also weigh up the natural history of the condition, and then look at whether you operate or not. There's no point in intervening if the patient's coping and you know they're actually going to get better. You've got to kind of practice, I think you've got to practice quite ethically and honestly, and say to the patient, these are your options, So also at the end of the day, it's important, very important to me that we're honest with patients and we say, this is the natural history and this is what we can offer. And so we shouldn't really be in the game of servicing people and operating. You have to really tease out who you can help. That's really important, looking at natural history. And we all know, like, people with disc herniations, a lot of them get better, but we see a lot of patients that have so much pain that they don't want to wait. I just saw a guy now before I left, he was in tears, he hasn't slept for a month, severe cervical radiculopathy, literally suicidal. So there's no point in saying go off for 4 months on Lyrica. There's also a lot of literature coming out on the adverse effects on drugs, Lyrica. I personally think in this country that we're going to look back one day and say we shouldn't have been prescribing this whole plethora of opioids. I think Australia's in a bad way in terms of you've got pain, reach out and get an OxyContin or something. I think it's absolute nonsense, and I think unfortunately that's something the medical industry has kind of inherited and passed on from maybe previous doctors, and that's something that has to be changed as well. You can't just treat pain with opioids, because you end up creating much bigger problems, and you end up creating two problems: dependence and pain. It doesn't fix the pain. But neurosurgery in particular is a really, really exciting field. Most days we probably spend about half our time using the microscope, doing sort of microscopic surgery, and then the other half doing more macroscopic surgery with loupes, where it's got maybe a bit more of an orthopedic flair. I remember working as a registrar and doing some of the old-fashioned fusions and just absolutely hating it. Opening everything, muscles bleeding, you've got the nerves exposed, you're retracting the nerves, and you're trying to get to the disc space, and then putting in screws and rods and closing up, and you think, shit, like there's no ways I'd want this done on my spine. It's just like barbaric, and that's how we were trained. That was like the gold standard, like and then with new technology, and it was fantastic coming to Australia. We had great opportunities where we could go to Japan, we could go to America, and all these courses. And we started learning, being exposed to different techniques. And some of the techniques that I've adopted that I'm really passionate about are particularly approaching the spine from the front, and then also the last 10 years doing a lot of lateral approaches where we're coming from the side. And the big advantages of some of these approaches are, if you can do an operation without cutting tissue or violating tissue, and you just separate tissue, it's so much less traumatic, and the patients really feel the difference. So A classic example is operating on the neck, like if you use this like a natural cleavage plane. And we literally, you can use like a cotton wool bud and you can separate those muscles. If you look in your lumbar spine, between your two big layers, I think it's longissimus and multifidus, there's an interfascial plane. And you can see it on MRI, and that's called a Wiltse approach. And it's actually perfectly kind of engineered. If you look at that, there's a muscle bulk there and a muscle bulk there, and then there's this interfascial line, and there's no blood vessels there. And sometimes when we do it, it's called a Wiltse approach. The guy was a surgeon from the States. You can do a small little incision, and I literally just use my finger, and I run my finger down there, and it separates those two planes. And that takes you right to the edge of the transverse process. So sometimes these days, if we have to put like pedicle screws in, that's how we do it. And so rather than stripping all the muscle off. And a telltale sign of it is if you look at post-op MRIs, sometimes you can see this horrendous tract of scar tissue. And if you know you've done a good job, if you look at it and you don't see any scar tissue, muscles folded back. And so those are kind of some of the advances. So that's one of the techniques that we do try and employ. But I think let me go back a step and say, there's also an old adage, you probably all heard it, keep it simple and keep it safe. So patients that do really well are patients with like severe nerve pain where there's a predictable surgical target. You go and take the disc out, free up the nerve. They just tend to be really happy, and almost on the ward round the next day they say my nerve pain's gone, and you know it's going to be. And so traditionally it's very important that we would train, be careful operating on axial, non-radicular back pain. In other words, someone comes in with back pain, be very careful. And you can imagine why. That's an absolute quandary as to what the pain generator is. Imagine all the different pain generators, the muscles, the discs, sacroiliac joints, facets. But that is also a little bit antiquated, and I think we have to be more proactive. So these days we use bone scans, we use diagnostic blocks, MRIs, and you can try and narrow it down and work out what's causing the pain. But so, and quite often we'll sort of even do a discogram. We'll get a radiologist to inject one disc and to see if it's discogenic pain. So the crucial thing is that every patient has to be meticulously worked up so that by the time you're operating on them, you know, is it discogenic pain, is it facet pain, or is it sort of SI joint pain and various other entities that won't respond to surgery. And the reality is, as you know from your patients, often it's a mixed bag. Yeah. So we have to be a bit cautious with discogenic, with just axial non-radicular back pain. The other point I want to make, Matt and I were talking about a case. Sometimes people think nerve pain is nerve pain, but if you look, this is a 3D printed model of someone's spine. If you look at this is the reality of what we're dealing with these days. A lot of older people, and they get a lot of spurs. It's all biomechanics. As bone rubs on bone, you get these massive platforms that form. And we see a lot of patients also with like foraminal stenosis. And you can see how, if you look at the foramen, and when you see patients, you should always try and work out, is there nerve compression in the canal or in the foramen? Because it's completely different in terms of what it's going to respond to. If it's in the foramen, also look at it and say, is that foramen closed in a vertical dimension like that, where the pedicle's sort of sunk down? Or is it in an AP direction due to a large osteophyte, which this patient's got as well, digging back in? So what we found is, when the patient's lying recumbent like that, if you decompress the canal, and it's pretty easy, they tend to do well. If you go and drill out the foramen, it doesn't really help them, because once they're on their feet, they've still got that vertical closure of the foramen. And that's why some of those patients need like an interbody graft where you actually put a spacer in. And so the problem with doing sometimes small operations, and if there's a high rate of recurrence where they don't work because of them collapsing, you just end up creating a lot of scar tissue. So as we get more experience in putting like spacers in anteriorly, quite often now even people in their 80s and 90s, if they're really struggling, will put a spacer in. And that's one of the sort of things that I've adopted over the years. I just want to show you, I brought this model. That's like a sort of traditional anterior spacer with a plate. But what we found was a lot of these spacers load in various points, because this is each person's geometry of their vertebral body is so different. And of late, the last couple of years, it's been quite an exciting journey. We've been sending scans to the engineers, and they make these 3D recons, and then they give us various like 3D printed spaces to fit. I think this is the wrong one. They actually fit perfectly in, so you can see that. So it's quite interesting. We did some studies on cadaveric bone. Like if you load that compared to a normal spacer, because it's a perfect surface match, it's so much stronger, and you don't get point loading where the sharp edge of the cage goes into the edge of the bone. Imagine stepping onto sand and you've got this perfect match with the sand. The distribution of forces are so much better. So this is something that I'm really passionate about, and what we find is we've seen quite a few old people with like scoliosis, where previously we wouldn't have taken them on, and now we're sending the engineers do a scan, and they do a recon, and they say to us, to get that patient back in alignment, and say you're doing like a 4-level anterior spacer, these are the different spaces you need. And then it's quite good, they give us like a virtual surgical planning. So they sit pre-surgery and they give us a model post-surgery. And that's where the concept of sagittal balance is crucial. And I think that's where there's a lot of overlap with chiro and surgeons. In the past, surgeons knew nothing about sagittal balance. They used to put rods in. Imagine putting a flat Harrington rod in a lordotic spine. It just doesn't work. And then in a couple of years, the next level's completely shot. But what's really, really interesting, if you fuse someone's spine in good lordosis, they've shown studies to show that the next level hardly deteriorates. So we always thought if you fuse it, they're working harder, therefore it's going to fail. But it was the way it was fused. So interestingly, if you actually fuse someone in a nice, perfect lordosis, and the next disc is parallel and not sort of working harder, it's incredible how much longer it lasts. So that's the kind of thing where maybe people think, okay, if you fuse it, the next level is going to fail. It's not, it's how it's done. So if you fuse it so that there's in a neutral sagittal balance. Sagittal balance is a concept of when you're standing side on, your C7 should be vertically above your sacrum. And if you see a lot of our elderly patients, they're becoming more kyphosed. As they become more kyphosed, they're putting a lot of torque on their lower back. And if you do an operation that makes it worse, they're never good, because their center of, and you've probably seen them, they all do this, they start rotating their pelvis and bending their knees to compensate, and then they start doing this. It's terrible. So those are the sort of parameters that we sort of look at with each patient before you take them on. But this technology has allowed us to, Matt and I were saying, we're talking about would you do 4 or 5 levels. We do, especially in the older people now, and it's allowed us to take it on. But you've got to be cautious. The other thing is, while we change disc replacement technology, the funny thing about disc replacement is there's a lot of misinformation. A lot of the patients want disc replacements, and we've also got to be cautious to explain to them that you've got to match the pathology with technology with the pathology. So in other words, not everyone's suitable for disc replacement. And this is, I'll just pass this around. This is an American disc that I've been using called Active L. And it gives you an idea. It's a polyethylene core on this is a very hard metal alloy that doesn't have any like particular debris or wear, and it articulates, and it's quite clever. It allows flexion, extension, lateral bending, and it even allows a little bit of translation. So this little core translates within by 2 mils. But the newer discs are going, this is still a ball and socket type model. And the problem with that is you put that into a disc, and then you're now forcing your facets to move in this sort of predetermined arc of rotation, where our natural discs are more like an elastic type thing. So that's why we also see quite a lot of facet joint pain with disc replacements, I believe anyway. And to give you an example, you've got to be very careful of putting a disc replacement in a steep environment. Think of patients with their pars fractures. L5 is wanting to slide over the sacrum, and it creates a lot of stress fractures or stress forces through that area. So those patients realistically actually do better with a more stable, solid, like a 3D printed spacing.
Right.
If you put this into that environment, they don't do so well. I'll just pass this around. It's worth just having a look at in terms of the biomechanics.
So, Mark, can you just go through
Yep.
like what you're looking at when you're choosing between a disc replacement and a fusion?
Yep.
Like why you would go one to the other?
So firstly, if you're going to do a disc replacement, they've got to have healthy facets. Imagine if you've got severe facet joint wear, you can't go and put in a mobile disc. It would make those facets articulate too much, and those would cause a lot of facet pain. So we grade facets, generally grade 1 to 4 on CT. Grade 1, where it's a very mild wear, you can generally get away with the disc replacement. But if you've got really bad facets, there's no point in putting it in. I mean, your facets have to move synchronously with your disc. And if these are bad and locked down, it doesn't make sense. The other thing is the level. L4-5, I've noticed the disc replacements at 4-5 tend to do much better because it's a nice horizontal disc.
Yeah.
So you don't have that translational sliding force. And what is quite a good concept is a concept of a hybrid, where if they've got 2 levels of discopathy, bad discs, you put in a stable one, and you actually put in a very lordotic cage to bring L4 end plate horizontally, and then you can do a disc replacement at L4. So we try and mix and match things according to the patient's pathology. But you do have to be careful because you can end up causing facet pain.
Yeah.
And it's not always plain sailing. Yeah. Other thing we haven't spoken about, I think is extremely important. We were talking about natural history, just to digress. Whenever you see patients with cervical issues, always take a few minutes to test their reflexes. Because the number of times I've picked up patients that are myelopathic where they've got cord damage just from doing a simple reflex. And it's a reminder, especially for me when I'm busy and I just look at the imaging but the number of times I've sort of picked up things just from doing a basic reflex, and they tend to be, if they're hyperreflexic or early spasticity, it gives you a clue. And those patients, be very careful with any sort of exercise, anything you put them through. For me, that's the one time I'd be very careful in terms of hyperextension, especially in the neck. And if the MRI scan shows a good buffering layer of CSF, you're generally safe. And if it shows that there's already cord compression with something called myelomalacia, those cases are very, very dangerous. I mean, we find even if we position them in hyperextension, they can deteriorate because think of the ligamentum flavum and the discs in a dynamic phase. And on the MRI, they could be okay, and in a certain position, if they become hyperextended, they can start damaging their cord. So always, try and have a sort of, don't just rely on imaging and that. Try and really also have a spend a bit of time clinically examining the patient.
So how does your approach differ with someone that has myomalacia compared to just DJD? And then how do you counsel people around that?
So if they've got established spinal cord damage, generally we would use that as an indication for surgery. And most surgeons would agree that once you've got that, it's called a high signal intensity changes on MRIs. And the best MRI to look at is the one where the spinal fluid is white, the T2, and you'll see whiteness or edema within the cord. And those patients generally need surgery unless they're really elderly and there's other confounding factors. But the problem, we do counsel them in saying that the natural history of that, even with surgery, 2/3 chance that you'll improve and 1/3 chance that you might just stabilize.
Right.
But most of them get better, but there's a small group of patients where they've got really bad fibrosis and they end up with a lot of burning in their feet. It's quite frustrating.
Yeah.
And you do a wide decompression, it doesn't change. But they are a small group, yeah. But that's crucial, picking up those patients, because you want to stop that natural deterioration with myelopathy.
So if you're referring those people onto physio or chiropractor, that sort of thing, how prescriptive are you in terms of, what you think we should do?
I would be very strong and say don't do any hyperextension, because it's we're using a lot of dynamic MRIs, especially that MRI in Blacktown, where we send patients for flexion and extension. It's fascinating when they've got tight cords to see the difference when they hyperextend. It like really shuts down. And then in a neutral phase and a little bit of flexion, it opens, and then, but in hyperextension, it's you can't believe the difference. So that's another thing is, you know, don't think of the spine just from the imaging. Think of it in a dynamic phase. And we should really be utilizing like standing X-rays or standing upright MRIs, because I mean, you know, we're not lying down all day.
So, what do you, for you, like if we're referring to you, what would constitute like a good referral, and what would be an emergency referral where we should say, what would be the signs that you...
So probably the commonest emergency referrals would be patients where they've got sort of unremitting pain and associated with some sort of neurological deficit. A common one we see is foot drop. It is quite frustrating. Sometimes we see foot drop that's been sort of treated conservatively for a long time, and that's foot drop's a really small thing that can be a devastating thing for the patient. As you know, it can be devastating on their stability, especially the elderly. They're a nightmare with falls, and devastating on their gait. So I honestly think anyone with foot drop, be careful to sort of persevere with treatment, because I think it's a bit of a double-edged sword. If you keep them too long and don't refer them and they don't get better, you're better off referring them really early and saying, you might not have to have surgery, but go and be assessed, have the nerve conduction test. So foot drop definitely. My absolute nightmare is old ladies with bladder dysfunction. I just want to run a mile, because, you know, you don't know, and sometimes they actually get worse with surgery, especially if they've got instability, they've got pelvic floor problems, they've had a lot of children. That's a really difficult thing to assess. But the classic cauda equina, where people have bladder and bowel issues, be very careful with that, because those just don't recover. And then, as I said, patients that are hyperreflexic, where you examine them, there's very brisk reflex, there's something impressing on their cord. I would refer them early. And patients with cord signal change. So probably those, foot drop, bladder and bowel, cord signal change, atrophy as well. But unfortunately, often, you know, by the time you see someone with a lot of atrophy, that some of that's sustained already. Right? But your bladder and bowel, that's also something I guess you just have to check with a lot of patients, where sometimes they don't want to talk about it. Just ask them, because you know, it's easy to sort of just glimpse over it.
So if when we refer someone to you, how soon after surgery would you be saying to the patient, you know, you need to go back to your chiropractor or your physio to manage the other levels?
So I think it depends on the pathology. Depends on the patient. I think some of our patients, especially some of the elderly, there's a group where I really just say to them, I think you should just sort of rest for about 6-8 weeks, just like recuperate. And I'm always scared of sending some of those patients back to physios or chiros in the community if I'm not sure what they're going to do. Because some of them are osteopenic, you've put these constructs in, and the last thing I want is someone getting them to like do something that they haven't done for 10 years. So I just tell them just 8 weeks. But then the basic stuff, you know, where we've done like decompressions and that really soon, you know, get them moving, probably within about 4 weeks, 3 to 4 weeks after surgery. Because the key there is movement, being active, and not just kind of waiting for things to settle down. But
does anyone else have any questions? I'm not asking all of them.
Are you doing the disc decompressions in the neck as well? You're only talking about lumbar spine.
We do a lot of them in the neck. When you're looking at neck surgery, there's two big categories of surgery. There's one where you do a foraminotomy. So the neck anatomy is completely different. So foraminotomy is if you get like a soft disc and it's burst and it's pushing on the nerve. It's a really good operation where we come in from the back, we flex the patient a little bit on the table, and we use that interlaminar window, and you can see that's a facet joint. We just drill a tiny little window medial to the facet joint, expose the nerve root, and generally you can sort of tweeze out a little bit of disc. So that's good if they've got arm pain. And then a lot of elderly patients don't have the soft discs, they've got the foraminal stenosis. It's also a very nice common operation. We just widen the foramen. We use a little 2mm drill with irrigation. And it's called eggshelling. We just drill until you can see the thecal sac. Remember, this is the cord, but the reality is you've got a nice layer of protective dura, and then you've got the ligamentum flavum. So I actually drill, and I use that ligamentum flavum as a little bit of a buffer, and you drill until you can see through the bones like an eggshell, and then you take a hook and you just flake that off. So it's really quite a nice operation to do. And then the other big category of surgeries is when you come in from the front, very common. That's really good if people have neck pain, axial neck pain, and especially, a lot of our patients have kyphosis. And you won't believe it, but every single week, especially in ladies, I'll see ladies that come in and say, "Doc, I feel like my head's too heavy. I've just got these headaches, occipital neuralgia, and I feel like my head is too heavy for my neck." They do terrible if you go and do a laminectomy because you're releasing that posterior tension band and you worsen their kyphosis. So that's why a lot of the old surgeries, I think, made people worse in the long run. You've got to think very biomechanically before you choose what surgical approach you do. No point in someone who's kyphosed and doing a laminectomy. And, you see these horrendous CTs where all the bones been drilled out and the patients then are coming in like this. Obviously, you can't release. This is an interspinous ligament, and that acts as a posterior tension band. Once you release that, especially in the elderly, they're going to become more kyphotic. So if someone comes in with a beautiful lordosis and you need to decompress them, you have that latitude to do that. But if they come in and they're already kyphosed, can't go in them. So keyholes from the front, and cervical disc replacement, that's also a really good operation. And I have to say one thing, the neck's much more forgiving than the back to operate on. Because think of the different biomechanics. This takes so much less weight than the lumbar spine. So we always joke at conferences and say you can get away with a lot more with the neck in terms of patients recovering quickly.
And how do you choose whether you're doing an anterior or a posterior approach? What's the
It's anatomy.
Okay.
So, and I'm sure it's the same with anything. You can't do a good job if you don't know the anatomy. So you look at the imaging. If there's a tiny posterolateral disc that's pushing on the nerve, and it's away from the thecal sac and the cord, you can sneak in from the back and take it out. But think of a lot of the discs that you see on MRI, they start almost centrally, and they're like a broad-based thing that goes out into the foramen. So there's no point in tweezering out a tiny bit of that and causing fibrosis, and you leave a whole chunk of ruptured disc anterior, So we look at the anatomy, and generally you're going to get a much better clearance from the front, because you can see from side to side. Do any of you pay attention to this little, probably the most neglected joint in the spine, on the corners? Hey? Yeah, the uncinate, yeah. And it's amazing how many people have neck pain, and you do a bone scan, and their disc has deteriorated, and they get this sort of sclerotic bone-on-bone loading with like ivory bone in those, we call them unconvertible joints. So that's just something to think. And that's why they're so happy if you put a spacer in. I think we just by jacking it open, it just takes the pressure off. And it's that really annoying pain that constant neck pain that doesn't get relieved with cortisone massages. What I want to ask you guys, because for years I've been telling people about inclinometers and traction. What's the evidence that ligamentotaxy or traction helps? And how long does it help for? Does it only help while you're hanging upside down? What are your thoughts on that? Because I often tell patients, go and lie on an inclinometer 15-20 minutes a day. As long as you're healthy, you don't have high blood pressure, and it's going to distract that foramen, maybe transiently reduce the nerve edema. Obviously when you're back on your feet it's negated, but I have seen it help patients. And I've also seen it help patients where you have a big ligamentous disc, and there's a big strong ligament called the PLL that we see when we operate it. It looks like an elastic band. It runs along the back of the spine. And if you see what happens when you traction patients, that PLL's tension, and it does sort of approximate things. So do any of you, I don't know if I'm kidding myself, but I do think it might be valuable. What are your thoughts? Be honest on that.
It does vary from patient to patient, and it depends on their stability too. Because I don't like the ones where they're already spondylolistheses.
Yeah.
But I think with a lot of people, once they're doing it repetitively, if they can commit to a routine, but I usually always start very small, short amounts of time, and it will vary from patient to patient, but they can generally progress and find longer weight-bearing relief after they've done some traction, say it's early morning, or if they've maybe even warmed up and had a walk.
And when, as a chiropractic group, when you train traction techniques, do those techniques keep your head in a neutral position, or do they cause extension or flexion in reality? Because that's something I often think about. I know the physios use various things to pull on or inflate collars, but I often wonder, if it's pure traction or if it's traction with extension or with flexion. Difficult to know, I guess.
We only learned flexion distraction. We didn't learn any other form of
Okay,
traction.
so flexion
Yeah.
and distraction.
Yeah.
That's mainly for the
And
lumbar spine, isn't it?
everything's kept neutral on the table, and
Yep.
the table actually drops,
Distracts.
and you can create different axes of movement.
Yep.
But nothing. The patient is always neutral,
Mm.
and there's nothing happening up.
What's the worst nightmare for a chiro in terms of like the patients you don't want to see? Hey?
Or
No,
physio.
I was waiting for that.
Chiro or physio. There's a lot of physios here. So I like seeing physios. I look after Phil.
The reason I'm asking is like, for me, one of the worst operations I do, and I do it quite often now, is elderly patients with like C1-2 severe arthritis, where they've tried everything, and that whole joint's completely gone. And we do a procedure using the body tom, the intraoperative CT, where we put in a screw in C1 and a screw in C2. But we're so careful of the vertebral artery because we're putting these sharp screws basically above and below. So we do a CT angiogram before, but it's just one of those procedures. As I'm getting older, I just like hate doing them because it's kind of hot, and you just really, it's quite nerve-wracking until they wake up. And but intraoperative imaging makes it so much safer because you can see on each plane. But still, having said that, I just my risk appetite gets less as you get older. And I was wondering if there's any sort of patient that walks through the door, you guys think, oh, you just can't win, whatever you do. I'm sure each profession has them, but
A slight sidetrack is vertebroplasty.
yeah.
And so we'll see crush. You'll see a lot of thoracic wedging. Where do you stand on vertebroplasty?
So, vertebroplasty, I think, in the right patients, a fantastic procedure. Even a geriatrician sent me a text message the other day. But the government withdrew the rebate for it a few years ago. It was really I think, based on. I thought it was prematurely done. That New England Journal of Medicine study that was done, saying there was very little benefit, but like a lot of these studies, if you analyze them and you look at who's driving them, it was quite flawed. So for me, if the fractures are quite acute, especially if they're involving particularly like the superior end plate for some reason, in the elderly, soft bone, they do amazingly well. But if you see, like I saw a guy yesterday, a young guy, he's osteoporotic, he's been on opioids, he's got multiple levels of wedging. It wouldn't make biomechanical sense to go and inject a whole lot of cement in each level, because there's not one particular pain generator. It's his kyphosis, he's got like 10% of wedging of his whole thoracic vertebra. And I'm not going to you don't fix your posture with...
So if there were one or two segments and it was more traumatic, would it be more...
Yeah, they do well. But then again, if someone's young, I saw a few like snowboarders, and they're in a lot of pain. But you say to them, look, you're actually going to get better in 6 weeks, so don't bother with it.
Yeah.
But the elderly patients do amazing with it. But you've got to be careful. If you inject cement in, I've seen quite a few patients with the next level in fractures. Because now when they're moving, you've got this incredibly hard structure, and it's amazing how it just has a domino effect. Yeah, but definitely a good procedure. We should be allowed to do it. It's frustrating. And there's another thing is, like, we do have a lot of patients that we see that say, Doc, I've got this leg pain, I don't want to have a fusion, what other technologies do we have? And years ago we used to have these fantastic little devices called interspinal spacer devices. And what they used to do is, and really I really would implore you, when you look at patients' scans, try and work out if there's foraminal stenosis and try and break it down. So a lot of those patients when they stand, there's a thing called the superior articular syndrome, where the superior articular facet of the one below rides up into the nerve root. And that's a dorsal root ganglion that comes out. The dorsal root ganglion, that's a part of the nerve that's exquisitely sensitive. So that's what Lyrica works on. But when you see patients that are in agony, it's not the ones in the canal, it's the ones in the foramen. It's like a little bulbous body on the nerve, and that has a sensory supply. And as they're standing, particularly the elderly, and they get a little bit of facet joint wear, and it does that hard, unyielding bone drives up, and it pushes it into the pedicle or the foramen. And those patients, like, that's a type of thing where we used to just put in these little devices, and they were really good. But then the TGA had a lot of old, antiquated surgeons that didn't know much about it, and they said, no, we don't have enough technology, we don't have enough randomized trials, and they like pulled the plug. But those are good technologies that I'm hopeful might come back. But unfortunately, they were introduced by companies probably with not enough studies, you know. So when they look.
So what's an alternative? Do you actually shave off the superior part of the inferior?
You must. A lot of patients that you end up decompressing, you can end up doing iatrogenic damage. Think about it. If someone comes in and they've got a partially scoliotic segment, partially sublux damaged facet joint, the horse is kind of already bolted. You then go and start drilling out that facet to decompress the nerve. You make it worse. Exactly. So the beautiful thing about those devices is it allowed us to indirectly distract it without weakening the facets. So and you always have to say to patients, I always say to patients when we're doing a micro disc, we're not repairing your back. Your disc has worn out and the other discs have look okay. So it's already a weak spot. It's then burst eccentrically on one side. We've taken out that piece. I'm not putting in a new, we haven't put in a disc repair kit or anything. So that's a reality. It's not, and that's why you get things like recurrences, and that's why they go on to post-discectomy syndrome where they have back pain.
Has anyone else got any questions?
There before,
Yep.
where it had a lot of anterior end plate damage.
Yep.
Do you see that affecting, like, say, the descending aorta or other organs anteriorly? Because, like, we talk a lot about posterior stuff, but
because they're so slow, they tend to just deflect them, push them out the way. But we do sometimes see some bizarre like syndromes where they compress a vein or compress an artery, but not commonly. We see more problems when we operate on them, and we try to swing them. Very easy to swing their aorta and the common iliac vessels, which we do for every anterior case, on nice anatomy like this. But that's a problem we encounter, and that's when we get quite bad bleeding. When you're moving the vessels, when you're trying to get it off an osteophyte to expose it, so that's when it causes problems. And of course, we do see this particularly in some older patients at the back. It's called OPLL, ossification of the posterior longitudinal ligament, and that's really hard to deal with because it actually sticks to the dura, and we see that in the neck. And we actually see it a lot. There seems to be like a genetic preponderance to that, OPLL. But the one thing, I don't know how much time you guys have to really get into neuroanatomy, but take the time to spend as much time as you can looking at the anatomy, because A, it's going to make your work more enjoyable, and B, you're going to have a little bit more confidence what you're dealing with. I just have a feeling that a lot of the trainees today, maybe their neuroanatomy is not as good as it used to be. In the old days, all the physios and everyone used to go to, I remember in South Africa where they used to join us in the anatomy dissections for 2 or 3 years, And you really have to know your anatomy and spend a bit more time than you would otherwise going back and really understanding the anatomy. Because it'll just make your work more enjoyable, I think.
I had a patient, just last week, who I'd actually referred to you through their GP, so you'll probably see them soon, with canal stenosis and foraminal stenosis and chronic back pain. Would you, I'll probably give you a buzz or something once she's seen you, but is it the kind of thing where you would go in, and if there's multifaceted issues, because you don't know the source of the pain, would you do multiple things in one hit, or are you just going to do it?
No, you're better off.
Disc or a facet
I think you're much better off. You're much better off just keeping it simple. So if everyday lecture, we see someone with severe stenosis and terrible sort of discs, and you say to them, what worries you more, your legs or your back? And if you can get away with just doing a decompression, we try and but you're better off practicing simply and conservatively. Because think about it, the more prostheses you put in, and the more you alter anatomy, and the more you alter the movement and the physiology, the more potential for problems. So generally I would always say to them, look, we can do this, and you might have to come back for part 2, but I'd rather kind of underservice you than go nuts and
That's
do
pretty
too much.
much what I told him, exactly,
Yeah,
because I said
because
you'll probably do that.
And also remember, we're not treating scans.
Yeah.
I mean, we all know, you see some patients and you say, oh my God, you must be in terrible pain. And they say, no, my back doesn't hurt, it's just my leg. And you say, you're kidding? Look at your spine, it looks dreadful. I mean, you see it every day. So correlation between imaging and pain is like so poor. That's what turns the whole science upside down. So you know, I think if surgeons are saying to patients, no, look, this looks terrible on your scan, we've got to operate. That's flawed science, think about it, it's not. And then the real challenge as well, think about patients with severe stenosis. Okay, they all mostly present with leg pain, but there are a cohort of patients where they get axial back pain or buttock like ischemic pain, and those are a little bit difficult to tease out because we do see a lot of patients where you can say to them, we'll do a decompression, but it might not actually help your axial back pain.
So around that, do you have any sort of examination pearls that you use to differentiate these sorts of things?
Yeah, I mean, I think that, so reflexes are always good.
Yeah.
Just check the reflexes. But reflexes aren't that helpful in elderly with generalized stenosis. It's kind of, straight leg raises, I always do it, but not always that helpful. Always look at tibialis anterior, so always get them to do that movement.
Yeah.
That's probably the most important movement you should check every time. Extensor hallucis longus and tibialis anterior. And the other thing is, I mean, you're actually going to get the most knowledge just watching the patient walking into your room. By the time the patient sat down, you should already be saying, it's hip, it's trochanteric bursa, or it's neuropathic. So you see the classic, we always see this straight away. I can say to them, oh shit, they've come to the wrong place. They've got that Trendelenburg gait. And then you get a mixed bag. And the worst are those with nerve compression, trochanteric bursitis, and pain down the ITB. You sort of, but don't operate on them. Send them for an injection. If they get better, tell them they can come back if their stenosis plays out. But I mean, the number of people that get treated for sciatica when they've got and for some reason I can't explain, it seems to go hand in hand with people. When they get nerve pain, they're in bed, or they're less active, and then their bursa flares up. It's really bizarre. It's almost like someone's throwing a curveball to confuse us. But it's it's common, really common.
And in terms of like examinations, with you looking at spical myelopathy and that type of thing, what are your tests?
So I always look at it first. Are they hyperreflexic or areflexic? Straight away, upper motor neuron, cord myelopathy, or a nerve issue. Strength, grip strength, especially in the neck, atrophy. Always look at the muscle groups for symmetry, especially C5. C5 is a really bizarre, C5 is the most sensitive nerve, it's the shortest nerve, and it comes out very vertically. So we often find after surgery, if we've tinkered with anything, patient says my arm pain's gone and they've got a C5 palsy, and they can't do that. C5 is very vulnerable. So always look, I mean, bulk, muscle bulk atrophy. The other important thing is patients sometimes don't always say is subtle fasciculations. We see that quite commonly. And then I always spend a bit of time looking at the intrinsic hand muscles, because that's really interesting. They don't tell you. The hallmark of a chronic sort of cervical myelopathy is the dorsal interosseous waste, and it's amazing how quickly it happens. Hyperthenar eminence and thenar eminence becomes very sort of wasted. And you can see some of these people that have worked for years, really strong hands, all of a sudden they just... And it's amazing once you get cord compression, it's like, there's like a switch. I saw that rugby player, you guys saw him in the hospital 2 weeks ago, Sonny Bill Williams. He had a slipped disc. within about 2 weeks, he's a massive guy, his whole tricep had sort of, and he said, Doc, I'm training, and this thing's just shrinking. It's like, he literally flicks the switch, and it's more than just disuse atrophy. I think it's that lack of synaptic sort of, so look for atrophy, look for fasciculations, and then if there's hyperreflexia, go back to the imaging. And that's also the interesting thing. Sometimes if someone's got leg pain, check their reflex, because you'll occasionally find someone with a long track sign from a thoracic disc or a neck that's causing neuropathic leg pain. And if we don't do their reflex, you wouldn't know. You'd be assuming it's back pain.
I've got someone who's got myelopathy in their neck and had previous surgery, but he's also got drop foot.
Yeah.
Is that common to have the drop foot? Because their previous surgeon was saying it was because of their myelopathy.
No, it's quite uncommon to have an isolated drop foot. So drop foot can come from 3 sources. Can come from, think of the motor homunculus with the brain. Tends to be, I've seen it a lot with patients with brain tumors, right over the vertex. So that's uncommon, but that can cause drop foot. Other thing, I've often seen patients with common perineal nerve, drop foot, so be careful. That's something we sometimes miss. That's where nerve conduction studies are useful. But not just from a myelopathy, unless they're really severe, but most myelopathic patients don't. So he might have some synchronous pathology lower down, or he's just had some fiber damage affecting that. I mean, think about every nerve fiber that goes to each myotome has to sort of come through the spinal cord.
Yeah.
But it's not that common. That would be pretty unusual.
Yeah, because I've sent him back to that surgeon and they're pretty adamant that it was fungus.
You'd be inclined to sort of definitely look at his back, and remember, drop foot usually comes from L4. It's either going to be L4-5, because that's the L5 nerve root, or it's L5-S1 in the foramen, where L5 gets caught in the foramen. S1 pathology is not going to give you drop foot, S1 obviously is plantar flexion. And the other interesting pathologies, obviously we sometimes see patients with a little bit of piriformis syndrome. I do worry that it's kind of banded around, and I do worry that when we don't know I worry that it's overdiagnosed without maybe, I think to have piriformis syndrome, you should either make sure that nerve conduction studies have shown there's a clear drop-off of conduction, or the MRI scan shows that there's damage at the nerve at that piriformis insertion. We just got to be a bit careful, maybe banding terms around. I always say to patients, I'm not sure. I don't want you to just put some label on it. I think the dogma that we have to make a diagnosis to feel more secure, I think we should rather just be straightforward and say it could be A, B, and C. I don't know.
Any last questions?
Yes. The patient presents, we had someone the other day who had no idea of how atrophied their whole left side was. And there was significant degeneration in the neck. Not so bad in the lower back, but it starts to make me think about the stenotic canals there and maybe fascicularis cuneatus and gracilis both being affected, and having that more global thing or a hemispheric thing, but there was, on the upper motor neuron test, they were right. But
So was their cervical spine quite tight?
yes,
Or?
very stenotic.
Yep. Yeah, I mean, that's...
Yeah. But there was also this kind of lack of awareness of, if you looked at your hands, which one's bigger, and it was and same with the feet, but it had obviously been long-standing, but also long-standing leg and some arm pain.
Yeah, it's amazing how some patients present early and other patients will live with pathology for years, and then arrive at your doorstep and you're like, where have you been?
Do you think that there is much involvement of the actual nerve tracts in those stenotic cases like that?
So when you mean the exiting nerve roots?
No, the actual tracts around that lower mid-cervical area where they're quite superficial.
Oh
broad.
yeah, definitely.
Yeah. Do you
Definitely.
see a lot of that?
Absolutely.
And do you see necks that you'll operate on their leg pain goes as well?
Yeah, absolutely. And and my anatomy there is getting a bit sketchy, but that's where anatomy is crucial. Think of the cross-sectional fiber design of the spinal cord, and it all makes sense. And there's also a thing called central cord syndrome, where patients have a hyperextension and they bruise their cord, or they get an ischemic vascular injury to the cord, and they preferentially lose their arm movement, and they've got maintenance of leg movement. So if you look at it carefully enough, you will almost always find a link between the anatomy and the pathology. and the radiology is a secondary thing, you know. So it's really interesting. There's also a thing called a cruciate syndrome, or cross, where you get sort of crossover, and then of course, you know, things like Brown-Séquard, where temperature. So you can always track those fiber tracks if you look at it, and it is. I mean, that's where I really envy, like the, you know, the old neuroanatomists, where they.
Just before you mentioned too about getting talking about different views that are attainable now, do you have any comment to make on the EOS scans?
You're really good,
Yeah.
really good.
Yeah.
I mean, we use them a lot now. We use them. It's amazing the number of times we've found like sacroiliac joint dysfunction, and also the number of times we've found leg length disparities, or just like quite major like knee issues that are impacting on their gait, and that's definitely. And when we're operating on multiple segments, we should be doing EOSs, and we'd use them quite a lot.
Yeah.
What are the group's thoughts? Have any of you got any experience in terms of these expensive PRP injections into the sacroiliac joints, which I send some patients to because I don't want to operate on them? Is it so the PRPs, when they take your blood, they spin it down and they inject it. I'm not sure. I think the jury's still out. But have you seen patients with?
We have a lot of sports medicine docs
Yep.
to do it.
I haven't had anyone with SI joints, but it seems to be working well with tennis elbows and stuff like that. That's the only.
And knees.
And knees, yeah. But they're all the sports docs doing
You
it.
know, SI joint pathology, I find it's challenging, you know, and especially ones where they've got really deranged SI joints and they have pain. It's really challenging.
Yeah.
But whilst I'm young, I've got at any point in time, any of you are obviously in small groups. Any of you are welcome, like Matt did, to come and watch surgery. Obviously, we always say to the patient, you know, someone is going to come and watch. We do mind, and generally they don't mind, and it's gives you a different perspective. I think it's so nice for you to see the anatomy. So this is a desiccated disc.
Yeah.
This is a healthy disc. This is the ALL. This is.
Yeah, and I would really encourage you all. It's a pretty amazing experience to do, and I remember saying to you, like, we've all seen gas signs on, and this person, and there was no disc. There was literally nothing there.
Yeah, it's empty.
It was amazing. I was like, oh my god, what's holding that up? You know, and I'd encourage you all. Not all next week, because I'm thinking of going next week.
But you're welcome. You know, it's definitely a great thing. Or if you have patients that you know coming to surgery quite often, you know, I've seen people sort of follow them to surgery and they've come in. It's good to see, because we can't practice in sort of bubbles. You know?
Yeah. And I think it's very good to be able to talk to your patients about it, because I've got some people. Well, Becky's our receptionist mum. I think you just saw her last week or the week before. She was freaking out about surgery, and you know, it was a simple discectomy, I think, and I just said to her, you know, they just go in and they make the hole bigger and bigger and they scoop it out and then it's done. She was thinking they were just going to have a big zipper off the back, you know.
My best days are when they're anaesthetised and you don't have to talk.
That's right. So, but it is a good opportunity to actually know exactly what the procedure is and what it involves and how quick it is to be able to go through that with your patients. So.
Mark, one question. We've had a recent patient present with a lot of radicular pain down the leg.
Yep.
Turns out with scans follow-up, she's got a cyst. It doesn't look like there's a major structural issue, but a cyst, and it looks like it'll be full of cerebrospinal fluid.
Yeah, Tarlov cysts.
So, yeah, exactly.
Yeah.
So at the moment, there's a bit of a wait and see approach.
Yep.
But if symptomatic, if her signs are still presenting, it's not severe but unrelenting, is it still just a wait and see approach?
No, you can help them with surgery. So there again, the surgical community in Australia is pretty conservative. They say don't touch Tarlov cysts.
Yeah.
But we see people with a massive cyst, and they tend to get like an aching type pain as well, sometimes through the glute.
That's exactly it.
Yeah, and then
through the glute and then foot pain.
Yeah, and what it is that if you look at the MRI, that cyst actually is compressing the nerve, and those neural fibers are all displaced to one side.
Because I've heard of aspiration, and then they can put like a sealant fluid in that basically helps fibrose or whatever.
I mean, my cousin's Dr. Curry, a radiologist, he hasn't said to me that really works. But what I have done in really bad cases is microscope, open them up, and marsupialize them. So you can actually see a tiny little like hole where it goes through to the CSF and the arachnoid. And I just take fat, just plug it, and then I just tether the nerve, because often the nerve's stuck to the wall.
Yeah, it's adhered.
And exactly. And think about it, every time we move our limb, if the nerves are adhered, it's going to cause pain. And that's one of the biggest problems with surgery. No matter how well you do your surgery, you're going to create some scar tissue. So I think also maybe the holy grail is if we could inject some sort of anti-adhesive barrier that actually stayed. So if any of you guys want to come and talk to me about a retirement project.
That's fantastic. So
Shockwave.
I think we can all
Thanks.
say, like, it's been a fantastic talk. I know I've got a lot out of it, so thank you so much. Right.
Thanks, guys. Have a good weekend.
Yeah.
Thank you.
Please eat some muffins.
Yeah.